How do I can't.
Nice. It's a great looking. Oh, yeah, you did it. Thank you for taking the time to help out with this Pearl of the Day. You mind just introducing yourself for everyone?
Hey, everybody. How are you? I'm Gary Maida. I'm one of the pediatric emergency medicine attendings here at Maimonides.
So, Gary, I just wanted to take a couple minutes today to talk to you about IV access in children, which can be a really stressful situation, particularly young kids. I feel like I really rely on the PEM nursing staff to get that line, and then everything sort of goes smoothly after that. But if they don't get a line, I'm suddenly saying to myself, like, oh shit, like, do I just go straight for the IO at this point? Or is it worth taking a couple minutes to actually find an IV? So the first question I have is, if the kid is like mostly stable, or you have a few minutes to poke around, are you cool with just an IO, like just get it in and get it done? Or do you prefer having an IV in these kids?
So, yeah, a couple of good points there. So definitely, I do not necessarily love IOs unless it's in the coding child situation. We have to rapidly give medications. Even when we get an IO in a coding situation, I still end up wanting an IV, especially for drips and fluids and stuff like that. In kids, it's a really small volume that are going through these drips, and you need pressure to get through the IO. Usually it's, this tight little line, and you need some pressure to get your drips through there. So usually that would run a lot smoother through an IV. IOs are great, but you often need an IV along with it. So yeah, it's very stressful when peds nurses who have been doing this for many years are amazing at putting IVs in all day, every day. And now they're going to come to you, the doctor, who maybe has never put an IV in a child, and it's your go time. And so we could talk about how we go about doing that.
Yeah, so let's talk about like a really young kid. Let's talk about like a 5-month-old that comes in and clearly needs a line, clearly needs access for medication administration and for blood. The nurse tries a bunch of times, both hands, they try in the feet, they come up to you and they say, Dr. Maida, I can't get this line. What's your sort of like next go-to step for a kid this small?
Yeah, so, obviously you should always look in the obvious places, the hands and the ACs, but I usually will trust that our nurses are experienced and they looked in those places, and I will actually go right for the saphenous vein. In pediatric patients where IV access is difficult, go for the saphenous. It can be, it's usually an incredibly juicy vein. You can get a bigger line in there than you would expect. Small babies, you had a 5-month-old in this example, you could easily put a 22 gauge IV in a 5-month-old saphenous vein.
You were showing me that really good looking ankle of yours earlier. Can you flip your camera?
Oh, wow.
And show me where that
definitely.
staff is?
Yeah, a little ankle action. Absolutely.
Yeah.
So when you're looking for the saphenous vein, what you should do is you should hold the kid's foot in flexion. Okay. So hold the foot in flexion like this. Locate the medial malleolus. Right. So the anterior border of the medial malleolus and this border of the tibia here. Sorry.
Yep.
Tibia, medial mal. Right in between them, your saphenous vein sits. So you can kind of feel this tendon here, feel your medial malleolus, split the difference. The saphenous vein is right in between there. In kids that are walking, sometimes you will see a big juicy vein right in that location. In athletes, unlike myself, you may also see a big juicy vein. But if you see it, great, you go for it. But even if you don't see it, you can blindly stick that area with a 22 gauge IV and be confident that you will likely hit the saphenous vein.
And you don't use ultrasound for this. You just go into that groove and just poke in and wait till you get flash and advance your catheter.
Correct. Yep. That's how I go about a saphenous vein line. Absolutely. If you go to the OR with peds anesthesia, you will see that their residents, when they need IV access, they'll skip the hand, the AC, skip everything and go directly to the saphenous vein. That's their go-to for a line. It's a great line.
So your saphenous vein fails. So nursing came up to you. I can't get the hands. I can't get the feet. I can't get the AC. You look in the SAF. You've been poking around for a couple minutes. What's next after that?
At this point, I would probably, so if the kid's 5 months old, maybe a little old, but don't forget about your scalp veins, you could kind of look for some vasculature in the head, shave a little area, assess the scalp veins. Don't forget about the EJ. I have a lot of soft tissue here. You can't really see the EJ so well, but theoretically it's over there. Yeah, because I'm an athlete, exactly. Put the patient, lie the patient in Trendelenburg. Let those EJs fill up and assess them. Put a neck roll under the patient. EJ is often a good place to put a line.
Can you get an EJ in a 5-month-old?
Absolutely. You can get an EJ at any age. 5-month-old will really have kind of a small neck. It may be difficult, but it's always a possibility. I would assess that location as well. I would grab one of my adult EM residents to help me put an ultrasound guided line potentially, looking at ultrasound guided peripheral line. And if the kid is coding, if the kid is very sick, you need to give something now and have no access. And for whatever reason, your IOs may not be functioning well. I have also placed a peripheral IV inside the femoral vein. Locate the femoral vein by way of ultrasound, put a big IV in there, and start your resuscitation. These kids need fluids, meds, whatever now, and however you can get it as sterile as possible is what you need to do.
Let's say you're in a situation where you just need that IO. You've got a young kid, this kid's less than 6 months old, and you're like, it's a code situation. I just need access now for med pushes. I feel like I always grab the IO gun, especially in my adult patients, and I'll go straight for the humerus, or maybe like a proximal tibia is usually my go-to place. Is that kind of what you do in these young kids?
Yeah, proximal tibia is definitely a go-to. You could get a great line there. Sometimes proximal tibia can be difficult in the really small kids, like particularly less than 1 month old, for example. There's a little bone and a lot of soft tissue, and your IO can kind of get lost in the soft tissue in that pretibial area. In this situation, I will actually go for the femur. Don't forget about the distal femur as a good place to put an IO. You can put a bigger IO there, and it'll be really it solidifies itself really nice inside the bone, and that's a good place for an IO. One thing to remember is that we have amazing nurses also up in the NICU and in the PICU. Get them involved as well. So you will place your IO by all means in the small coding baby and start your resuscitation. But perhaps you can get on the phone with NICU and PICU and have them send down their most experienced IV nurse to come help you out as well.
When you were saying a bigger IO, we have those, the small pink ones that I always think of babies, the medium blue ones that I think of like as regular adults, and then the huge yellow ones that I think for like, extenuating circumstance. When you say a bigger IO, are you putting like a blue IO in the femur of these like young kids?
If you look at the pack of the blue and of the red, it tells you the kilos for which to use those IOs. I forget exactly what it says, but one of them is like, for 3 to 39 kilos, use this. And then another one is for kids greater than 3 kilos, use this. It's very confusing. So in a small kid, if I see a nice big femur, I will put the blue IO in the femur. Typically, we only use these red ones for the small babies, but for the femur, if you think you have a big, juicy bone there, put the blue IO and give it a shot and start your resuscitation.
Super helpful. Thank you for taking the time out of your shift. I really appreciate it. And hope you have a good rest of your shift.
Thanks, Duncan. Have a nice day, man.